currently working as Associate Professor in the Department of Psychiatry at BRD Medical College, Gorakhpur, in the state of UP, India. Also simultaneously, I am working as a visiting professor at Universal College of Medical Sciences, Bhairava, in Nepal. I did my MBBS from BSS Medical College, Bulla in Sambalpur in Odisha. Subsequently, I completed my post-graduation with diploma as well as MD from Central Institute of Psychiatry at Ranchi, India. Here, I will give a small lecture in relation to epilepsy and epilepsy scenario in India. So before going to the main lecture, I would like to clarify certain terms: epilepsy, seizure and convulsion. Many times these three terms are used interrelatedly, but in a scientific connotations they convey a little bit of different meanings. Seizure is basically the series of abnormal electrical discharge in the brain manifested clinically as seizure. Convulsion is the motor manifestation of a seizure activity, and epilepsy is defined as two or more attacks of seizure in a person over a period of time. So thus we have two different classifications. One, a classification of seizure, one is classification of epilepsies. Before going into those classifications, I would first like to say a few lines on how common is the epilepsy in India or in the world scenario. It is said that overall it's about 50 millions of epileptic patients are there in the world nowadays. Among them, around 8 to 10 millions of people are suffering from epilepsy in India. It comes around 5 to 8 persons per 1,000 populations in India. So what is the pattern of newly diagnosed epilepsy? It is said that among the various types of or patterns of epilepsy that has been described, around 30 to 35 of patients are diagnosed as generalized tonic-clonic seizures or epilepsies. Around 50 to 60% of patients they suffer from focal or partial epilepsies. And other form of epilepsies like absence seizures, they contribute very small percentage of overall percentage of diagnosis of epilepsy. Does epilepsy carry any mortality or morbidity? It's an important question. The extremes of age basically they carry increased risk of mortality. Epilepsy diagnosed the less than 1 year, or when the epilepsy for the first time diagnosed beyond 60 years of age, they carry the increased risk of mortality. Morbidity risk is high in case of primary generalized seizure because there is no warning signals in them, there is no aura. So there is chances of injury, burns and scars are there, or other varieties of morbidities are there in case of epilepsies. Now the question comes, how many percentage of patients of newly diagnosed epilepsy really reach to the doctor for treatment? It has been estimated that around 80% of cases, some says that between 60 to 80% of newly diagnosed epilepsies never reach to doctor in a South Asian countries or the basically developing countries like us. This is considered as a treatment gap. So there is still a huge treatment gap in relation to diagnosis and the subsequent step of receiving treatment from a qualified doctor. So who are the persons who treat these epilepsies? In a country like us, in a developing country, many of these first time diagnosed epilepsies, they don't come to a treating professionals. They basically seen and being treated by unqualified or partially qualified or other poor persons. That leads to chronicity of illness and maybe in many times inadequate and incomplete treatment leads to resistance of cases. The next question comes that who amongst the professionals who treats epilepsies? There are many claimants: general physicians, pediatricians, neurologists, psychiatrists, neurosurgeons, gynecologists, besides all other various doctors. They all claim that they treat epilepsies. So even all these professionals combining together, they treat probably around 15 to 20% of newly diagnosed epilepsies. So there is a need to train the partially trained doctors or the cohorts or the other health workers in the community, that they should be treated, trained and trained for adequate diagnosis and trained for proper treatment for these epileptic patients. And wherever possible, the newly diagnosed patients to be referred to proper experts, personnel for treatment. Now coming to the classification of seizures and epilepsies. They said that seizures are basically divided into two varieties, that generalized seizures and partial seizures or focal seizures. Focal seizures are also again divided into simple partial seizures and complex partial seizures. Focal means only a part of the brain is involved and thus a part of the body is manifested. Focal seizures may be sensory varieties, may be motor seizures, may be autonomic, may be psychic. So there are more than 200 types of focal seizures has been described in literature of late. The most characteristic feature of a simple partial seizure that patient knows everything what is going on with him or her. That is, it is done in fully conscious state of mind. In case of complex partial seizure, this consciousness is impaired. Probably patient can narrate a part of his or her the problem he or she is undergoing. Then when on the part of the brain, the entire brain is involved, patient loss his consciousness completely. And the seizure spreads to the entire brain, we call it generalized seizure. So generalized seizure is again divided into basically two subvarieties. Generalized seizures, which starts with a focal component before, it's basically secondary generalized seizures, and generalized seizure without any prior focal component, that is without any order, that is primary generalized seizure. Generalized seizures, again there are several subvarieties described. Generalized tonic-clonic seizures, generalized tonic seizure, generalized clonic seizure, generalized atonic seizure, absence seizure, and so on. A common man, a layman, can diagnose generalized tonic-clonic seizure. There is no credit, I call it this way to my students, there is no credit in diagnosing a case of generalized tonic-clonic seizure. Anybody can diagnose and say that he is throwing a seizure. The credit for an epileptologist or an expert personnel in relation to epilepsy is to diagnose other generalized varieties of epilepsies or other partial epilepsies. For example, how does a generalized atonic seizure presents? The sudden drop attacks probably indicates a atonic seizure. A brief period of tonic contraction of the entire body, that indicates a generalized tonic seizure. And absence seizures. I considered myself as it's a bit difficult to diagnose the various types of absence seizures. Absence seizures are diagnosed because of the number of attacks the child is experiencing all throughout the day. It's mostly seen in young age, preschool or school-going children. A number of attacks, maybe 50, 60 or more than 100 attacks per day, and each attacks are of very brief duration, in seconds. They say it's 15 to 20 seconds at the most, going around a minute or so. So it is the number of attacks that is most important. How does it present? Most important presentation is that the ongoing activity in the children is stopped for a brief period. Whatever the child was doing prior to the attack, that activity is stopped. He may stop walking suddenly, he may stop taking food, he may stop reading and remain in that state for few seconds. And when the parent or teacher or the student scolds what has happened, why you have stopped, then again he starts. So the sudden stoppage of ongoing activity is a most prominent feature in the manifestation of absence seizures. Another variant is, in addition to the sudden stoppage of activity, there is appearance of some repetitive movement, repetitive eye blink, chewing movements for a brief period. For example, patient while eating suddenly stops and then he starts blinks, and then he gets back to normalcy. So this may be a very presentation of absence seizure. Absence seizures, and again there is a EEG diagnosis is there, classical 3 Hz per second seizure discharge are there in absence seizures. So this and there is another generalized seizures which is most often missed by common clinicians, is myoclonic seizures. The sudden jerky movements of a part or the whole of the body. Maybe a single episode or maybe multiple episodes over a period of time. And mostly occur as the patient goes or the person goes into sleep or gets up from the sleep. There is jerky movements, a sudden single or multiple jerks of a part or the whole body. When it involves into the whole body, they say the patient may be thrown out of his chair or even from his bed. The myoclonic jerks are basically indicative of some underlying organic brain pathology. Then coming to the classification of epilepsies. So what I have just said, that is the classification of, the brief classification of seizure. Classification of epilepsies, basically epilepsies are divided into three varieties. Idiopathic epilepsies, for which there is no apparent cause is known. Cryptogenic epilepsies, for which there is some apparent cause is there, but still it is difficult to pinpoint the pathology. And then there are symptomatic epilepsies, for which there is definite cause or the brain pathology is known. So epilepsies are classified based on these three concepts. Now, after this, knowing these epilepsies, the classification of epilepsies and seizures, how we really assess and diagnose seizures or epilepsies? The question comes here, please. What is what are the most important features or factors or the points in relation to diagnose epilepsy? We have to assess both the person or the patient himself, the description of the seizure by the patient, and the description of an eye observer. In case of partial seizures, probably patient is in a position to describe everything what has happened to him or her. In case of simple partial seizure. In case of complex partial seizure, the patient will be in a position to describe a part of his or her illness. And in case of secondary generalized seizure, that means persons with a aura, with a history of aura before patient goes into unconscious state, will be in a position to describe what had happened with him or her just prior to becoming unconsciousness. Then we have to inquire the eyewitness regarding the detailed nature and presentation of seizure activity. Epilepsy being mainly a clinical diagnosis, we depend heavily on interviewing patient as well as the eyewitness. Basically, all the investigations that has been done to exclude the possible causes of symptomatic epilepsies, not to establish a diagnosis of epilepsy. Epilepsy is a clinical diagnosis. Now, all said and done, what are the classical symptoms of epilepsies? If the patient present with all those symptoms, you are sure that probably I am dealing with a case of epilepsy. This is among the very vast arrays of symptoms. One of the most important symptoms that is in clinical presentation of epilepsy is probably tongue bite. Tongue bite, particularly bite on the lateral aspects of the tongue, gives a definite indication of a true seizure activity. If the tongue bite at the tip of the tongue be suspicious, maybe we are dealing with a case of pseudo seizure or psychogenic non-epileptic events. Similarly, the involuntary passage of urine during unconscious stage gives a strong indications that we are dealing with a case of true seizure. Significant injuries, burns, scalds at the time of attack also indicates probability of a true seizures. In establishing epilepsy, we have to rule out other medical conditions. So what are the other probable medical conditions that may mimic epilepsies? I think most common and the most important is the psychogenic non-epileptic events which mimic epileptic events, or what is called pseudo seizures. This is being an area of a psychiatrist, but I think all epidemiologists must know the distinguishing points between a true seizure and a pseudo seizure. The first area of symptoms that differentiates between these two, I will delineate few important ones. So there are certain indications are there in history, certain indications are there in clinical presentation which differentiate true as well as from that of a pseudo seizure. So having an history of strong stressor, some acute stressful life events just prior to the event probably indicate that we are dealing with a pseudo seizure rather than a true seizure activity. And if we get a history of known psychiatric illness in the patients, the known patient is a known case of depression or anxiety or some other psychiatric illnesses and our regular treatment, and if the person is throwing a seizure, we have to be doubly sure in making a diagnosis of true epilepsy in those cases. And how clinical presentations differ. The most important being that you ask for the duration of the seizure. True seizure rarely last beyond 1 or 2 minutes. And most varieties of true seizures, unless it is a epileptic emergencies and status epilepticus probably, most true seizures or most epilepsies rarely last beyond a minute or two. If the patient's guardian says that patient threw seizures for hours and hours, which lasting hours, probably we are dealing with a case of pseudo seizures. Then you inquire the pattern of body movements. True seizures are usually what we call that is that there is a rhythmic, jerky movement of the body. Whole body moves in one rhythm. In case of pseudo seizure, it is the opposite, is it true. The body moves in an arrhythmic manner, what is called out of phase movement. In phase movement in true seizure, out of phase movement like this, it's probably dealing with a case of pseudo seizure. Also, the cry, epileptic cry and pseudo seizure cry. Epileptic cry is a decrescendo sounds which comes out of throat at the beginning of the tonic phase of the seizure. Something like that. But the cry in a pseudo seizure, it's what is the most that described by the patient guardian is that yes, does the patient cry? Yes, he cries. How? Just like a normal cry. So if the patient guardian describes something like that, we show that we are dealing with a case of pseudo seizure. In pseudo seizure cases, they rarely injure themselves, rarely there is a passage of urine and stool, and rarely there is a tongue bite, if at all, only the tip of the tongue that is bitten. And mostly you get a significant stress before the precipitation of that pseudo seizure. But is it easy to differentiate true and this pseudo seizure? All said and done, all these things are written in books. It has been highlighted during lectures by all these clinicians. But simultaneously, it has been seen in the most advanced epileptic centers in the world, not only in this part of the world, not only in the small these centers. The mistaken diagnosis of pseudo seizure as a true seizure is very, very high. They say almost 5 to 10% of the patients in epilepsy OPD is probably are cases of pseudo seizure. And in a case of a ward epilepsy, where the patients of epilepsies are receiving treatment, as high as 25 to 30 patients of resistant epilepsy cases has been the diagnosis has been reviewed, and a diagnosis of pseudo seizure has been given. It is not the most of it's a very that it's a very startling figure. Around 30% of cases in a epilepsy ward which is not responding to treatment of standard epilepsy regimen, probably cases of pseudo seizures. I myself have dealt with cases of epilepsy, a diagnosed epilepsy, diagnosed status epilepticus, admitted in a ICU, non-responding to drugs for several days. Then I was called for a review, and I found while taking history, the patient has the known history of depression, had a history of suicide attempt in the past, and presented with classical pseudo seizures. After appropriate interventions, the seizure was controlled. So this pseudo seizures mimicking as a true seizure, it's a difficult diagnosis many times even to the experts in the field of epilepsy, not only in our country, probably it is the same figure worldwide. So does the really patients need treatment? The long-term follow-up of patients who receive treatment and who has not received any treatment, probably if you follow up these two group of patients over a period of 15 years, 20 years and other things, probably there is not much difference in the mortality rate in the persons who has received treatment and who has not received treatment over a period of time. But morbidity definitely affect these persons who has not received treatment. Their the lifestyle or the quality of life definitely hampered over a period of years and decades in case of persons who has not received treatment. Another important thing, if you treat the patients, there is always the chances of recurrence of epilepsy or the seizures will be minimal. Patient will have a healthy life, and quality of life are assured in a persons who receive treatment. So that's why treatment is necessary, because giving a treatment only, you cannot assure that his epilepsy is cured. Probably only 50% of cases of partial epilepsies are treatable. It's around 80% cases of generalized tonic-clonic seizures are treatable. So you start with a single drug based on the type of epilepsies you diagnose. Go to the maximum possible admissible dose or the maximum tolerated dose the person can tolerate. If the epilepsy is controlled, well, continue with the same dose, preferably for a period of 3 years. And after that, you try to taper off. That is the standard procedure we follow. But this standard procedure is not true for all forms of epilepsies. Probably symptomatic epilepsies, they need a lifelong treatment. Probably these partial seizures, they need to be followed up more carefully for a more longer period. And when the single drug is not responded well, you review the diagnosis, go for more further investigations, try to establish whether your diagnosis of epilepsy is certain or not, true or not. Then you go to the second anti-epileptic drugs of the same group. If the seizure is controlled, well, continue with the second drug. If the seizure is still not controlled, probably then there is a need to add a second anti-epileptic drugs from a different group. And this way we go for permutations and combinations over a period of time. At a certain stage, probably a small percentage of cases, maybe after initial diagnosis of 100 patients, a 5 to 10 or around 15 patients that remained resistant to epilepsy, standard epileptic treatment. We call it resistant epilepsies. And there are different approach to all these resistant epilepsy cases. I will not go into, I don't have the time to go into detail of discussion of how to approach and what are the treatment or surgical treatments available to resistant epilepsies. So, in concluding the lecture today, the message what I want to convey to the general public is that if someone in your family, in your locality, have the history of throwing a seizures, probably the person has an epilepsy. It is better that you take that person to an expert in the field of epilepsy treatment. Do certain minimal investigations, establish the diagnosis of epilepsy and institute treatment. Treatment is necessary definitely during the initial part, and follow the doctor's advice on the duration of treatment as the doctor's advice to you. Now another interesting question here comes that when shall we start treatment in a case of epilepsy? As I said that we don't treat a single seizure attack. We treat epilepsy. Epilepsy is a seizure attack of 2 or more. So unless if someone comes with a single seizure attack, we usually don't start anti-epileptic treatment on those persons unless there is strong other indications. Someone who has got a very strong family history, someone who was presented at the initial stage with a status epilepticus. Probably they need treatment from the first attack onwards. And another common mistakes what I find that is this mistake is done not by the patient or patient guardian but by the clinicians. Is when we call it a single seizure attack and when we call that attack is 2 or more. If the person through seizures 2 or more attack within a span of 24 hours, shall we start treatment in those cases or not? It has been said and established that a cluster of 3 or 4 seizure attacks, 2 or more attacks within a span of 24 hours is usually taken as single seizure attack. So unless the person through 2 independent seizure attacks over a gap of more than 24 hours, we don't start treatment even if the person through 2 or more attacks within 24 hours. This is where the mistake is commonly done by clinicians. The patient has thrown 3 or 4 attacks within 24 hours, then they start off treatment. And another common mistakes done by clinicians is someone who has thrown seizures, 2 or more seizures, has come to you or during 3rd or 4th seizure, you start with Eptoin regimen. That emergency regimen or the status epilepticus regimen. That is again not necessary. You start with standard anti-epileptic treatment, not an emergency treatment in this case. So you have to ascertain the diagnosis of epilepsy. You have to ascertain the diagnosis of seizure. Next, you have to ascertain the diagnosis of epilepsy. Then you start treatment and continue treatment as long as it is being advised by your clinician. Shall I stop here? Thank you.